All right, so this is the second video in our series of trying to get somebody weaned off of mechanical ventilation and positive pressure. At this point is the management phase, but first thing we're going to talk about is COPD blood gases. So someone with COPD, their blood gases are different than a normal person's blood gas, and that's because patients with COPD work off a hypoxic drive to breathe, which means instead of relying on carbon dioxide chemoreceptors for their respiratory cycle, they rely on oxygen chemoreceptors for their respiratory cycle, which in short really means that us as people without COPD, we rely on the chemoreceptors of carbon dioxide to breathe. So our brain, our body is going to tell us, hey, we're building CO2. We need to breathe this off. We need to breathe a little bit more, or vice versa. Hey, we don't have enough CO2. So that's where our mechanism for breathing comes from internally. And for people with COPD, it's the opposite. They have low oxygen content, so they're trying to breathe for more oxygen. They want more oxygen at all times. And so the hypoxic drive makes the arterial blood of the gas of the COPD patient skewed from the norm, typically a lower pH, but still within our normal limits, and a higher concentration of PaCO2, carbon dioxide, and a lower concentration of PaO2. So they are having that higher amount of carbon dioxide as their normal and a lower concentration, but it makes their body still want, instead of going off of that, get rid of CO2, it's get more oxygen. So normal ABG for people without COPD is pH 7.35, 7.45, PaO2 80 to 100 millimeters of mercury, PaCO2 35 to 45 millimeters of mercury, and bicarb of 22 to 26. And for someone with COPD, an average or a normal one would be 7.34 to 7.37, slightly acidotic compared to what our range can be, even though they're not acidotic at this point, but going towards that spectrum more than alkalosis. PaO2 of 55 to 65, which is significantly lower than ours, from 80 to 100. At PaCO2 of 55 to 65, which is higher, range of 10 to 20, and bicarb of 28 to 34. So for a person with COPD, a special precaution for Mr. Rudd, my patient, other than the COPD, is that he has COVID. So I'm going to be wearing full PPE gear while in the room and assessing the vent and talking with him and trying to get him in this weaning process. Other special consideration precaution would be that because of them wanting that more oxygen, and now that we've had them on a ventilator and their body's not having to breathe to get that oxygen, is their body is more comfortable on that ventilator because we're doing the work for them and they're getting oxygen. They don't need to do anything because they don't have a drive to get rid of CO2. They have a drive to get more oxygen, and they're getting it without having to do anything. So when it comes to weaning and being on the vent in general, I need to have the approach of as minimal settings as I can to keep them in a good state. Because the more oxygen I give them, the more PEEP, the more comfortable their body gets in that range, in that realm, and doesn't want to be taken off of the ventilator. So then that's where you get into that trouble of weaning and getting them extubatives because their body's comfortable right where it's at. It doesn't want to work. So it's not doing any work on the vent, and it doesn't want to now. It wants to get all those things without having to do that work. So those would be some precautions there that I would take with Mr. Rudd or any COPD patient or anyone with COVID as well with the PPE. So Mr. Rudd is now has stable vital signs for his pulmonary history. His heart rate is 82, SpO2 is 94, blood pressure 102 over 73. And the attending physician has requested for me to wean Mr. Rudd to minimal mechanical ventilation values of a SIMV to a rate of 4. And due to his longstanding COPD, that we're going to kind of stair step it in that process. And that's what he's looking for us to do here. So first and foremost, to get started, I'm going to explain the process to Mr. Rudd. So in talking to Mr. Rudd, I'm going to tell him, hey, so what we're going to do now that we've got you've turned off your sedation and you're awake and you're breathing and you're here with me and we're talking, we're going to start lowering the values on your ventilator to help to have your body breathe by itself a little bit more and get a little bit stronger. So you're going to feel um, less control from that ventilator, and it's going to be we're going to be wanting you to be working on your mechanics to breathe on your own. So just be calm and just do your best. Take slow, big, deep breaths. Breathe normally. Try not to breathe a lot or rapid or shallow. And that I want to be here with you to coach you through it all and make sure that you're in a good place. So explain to him that that's what we're going to do. And also at the beginning, I'm going to do what's called an ABG. So we're going to stick you for some blood because I want to see how well you're oxygenating and your pH and your PaCO2 values are before we start you on a different mode of ventilation, or at least taking away some values of that ventilation for you. So first thing, I'm going to get a blood gas pre after I've explained to him what this process would be and what we're going to be doing. So his current ventilator settings before we start manipulating anything for the weaning process, he's on SIMV volume control, set rate of 400 mLs, 450 mLs, excuse me, set rate of 10 breaths per minute, spontaneous tidal volumes 250, which is low for where we really need it to be because it's showing that his body is not having to work very much. Total rate's 13, pressure support of 5, PEEP of 5, and FiO2 of 35%. And here's a picture of the vent. This is a Puritan Bennett. I believe that one would be a 980. It's actually showing in a spontaneous mode, so that's not where we're at currently, but that is a pretty standard vent that you see in a lot of different hospitals there. It's even got a heated circuit with humidifier on there as well. So I went ahead and we poked Mr. Rudd, got an ABG, and this is his pre-SBT value, so we can see how he's doing before we start manipulating the vent. He's got a pH of 7.35, PaO2 of 67, a little bit high from where he normally should be, but he's on a vent getting oxygen given to him, so it's not that bad, not out of range really too much. PaCO2 is 59, a bicarb of 30. So everything's in normal range other than that PO2 is slightly high for where we really want him to be. So now that we've got the ABG and I've explained to him, so we're going to start this weaning process. So the weaning time frame I have is 30 minutes to 120 minutes. That's how long we can wean Mr. Rudd here. So some changes I'm going to make during that time would be I'm going to manipulate the rate and try to lower it to that rate of 4 that the doctor asked for. But since I have that much time to go with, and since he's had trouble weaning in the past, I'm not going to drop his rate from 10 to 4 initially. So initially, I'm going to drop his rate from 10 to 8, trying to get his body to breathe a couple more times on its own because he's still 8's viable, especially when he was doing 3 breaths on his own. And drop him to 8 and monitor him during that time and see how well his body compensates and how he's doing. I want to make sure that I'm not seeing him having to struggle to breathe, any increased work of breathing, being agitated, diaphoresis, his SpO2 drop, or any retractions going on. And so I'm going to do that in increments. And along with that, I'm going to do other settings as well, like his FiO2, it's at 35. I'm going to tailor that off as well because that's not a high FiO2, but that is a little bit higher than where I would like for a COPD patient that I'm trying to potentially that I'm weaning that I want to potentially extubate soon. So as long as his SpO2 is still in that good range, it's not dropped 4% from his 94. He's still in that 90 to 94 range. I'm going to lower his oxygen level as well from 35 to 30. And I could do this all within that hour and 20 minutes incrementally and go up if I need to again. Just not, I don't want to go up past where we began at. So other than the FiO2, his PEEP and his pressure support were set at 5, which are minimal values really for where we're trying to SBT and wean. So with his weaning, I want to lower that rate, which I've done by 2, and then lower it again, hopefully within a 10, 15, 20-minute range, just to monitor him while he's doing that, make sure that he's not digressed in any way in that SpO2 or work of breathing or agitation or anything like that. And if he has started to show some agitation when I've decreased a rate, instead of going ahead and adding that rate back, since I have that pressure support at a low value of 5, I can increase that pressure support to 6, 7, 8 to give him a little bit more ease. Because what pressure support does is once he takes in a breath, it gives that breath a little bit easier for him. So he's not having to do all the work of those muscles on his own and give him a little bit more time to start to build his muscles back up and a little bit at ease with that. And then, like I said, incrementally, I want to continue to drop those things. Continue to monitor him, but at 30 minutes, is he doing well at that rate of 8? Is he maintaining very well? I'm going to drop it to 6. and then also do the same process, manage him and watch him and see if maybe I do need to increase that pressure support a little bit, or maybe not. Maybe we're good where we're at. Maybe he's doing good still at that rate with, and his SpO2 still within that 4% range of dropping. Then maybe I'll drop his FiO2 again, which I would love to get it dropped to 28% before we take him off. 30% is fine, but 28 would be better if I could, and just continue to monitor and make sure that he's not desaturating in any way. And good ways to monitor oxygenation and ventilation invasively would be that ABG. So I got that ABG beforehand, so I know where he was at with everything and where what range he was at and how well he was doing beforehand. And then that would monitor not only his oxygenation with the PaO2, but his ventilation, because I'll see his PaCO2, and those would be invasive. That would be an invasive way to do that, but we're definitely going to do that pre and then before we finish as well, before we go into extubation. And then a non-invasive way to monitor his oxygenation would be just a pulse oximeter. We have one attached to him. I can watch the monitor and make sure that his SpO2 levels are not dropping any, that he's not going below that where we're looking at 90%, and that he's still oxygenating well. And to non-invasively monitor his ventilation, there's several ways really. Mostly I would say is just monitoring him and doing a physical assessment and seeing, is he getting diaphoretic, is he trying to struggle, is he struggling to breathe, is he agitating, or am I seeing any retractions going on? And then other ways would be watching your vent settings and what's coming back, like what is his spontaneous tidal volumes, are they really low? Is his rate increased from his spontaneous from 3 to now 15? Because if it's at 15 and he's at breathing, getting 6 breaths on his own, then we're at a rate of 21 and we're dangerous close to that 25 mark, and he's having issues at that point. So that's another way to monitor that as well, and just monitoring, looking at the waveforms. But then another way would be capnography. If you're at a hospital that has that in line with the vent in their protocol, you just have a value on your monitor that you can look at to see, how much CO2 is he breathing out at each moment. Is it increasing? Is it decreasing? So I can see how he's ventilating at that portion as well. So that's the management phase of how I would do that with him, is most importantly the stair step and monitoring, incrementally lowering those values as much as you can, but without him deteriorating, and while his muscles are growing and getting stronger during that process.